Bismillah ar-Rahman ar-Rahim. This session is a very unique session. Actually, we have been preparing for this session for more than a year, and I'm really so honored to have Professor Salman Tesfaye. Professor Salman Tesfaye is a leading diabetologist and honorary professor at the University of Sheffield, UK, with visiting academic roles in China. He is an internationally recognized for his work on diabetic neuropathy, with over 250 publications and an H index of 86, and the leadership of the widely cited international consensus guidelines on its diagnosis and management. And actually, Professor Tesfaye is a winner of Lifetime Award, yes, for his achievements and research work in diabetic neuropathy. So let's enjoy our session today with Professor Tesfaye. It's so honored to have you with us.
Thank you very much indeed, Dr. Noha. This is a great pleasure to be in this very beautiful city of Alexandria to give this lecture. I've been to Cairo many times, but this is my first time in this beautiful city, and so it really is a great honor to speak to you today. I hope I can be heard from the back. So let's put this in the presentation mode. My title today is Epidemiology, Pathophsiology, and Recent Trials in Diabetic Neuropathy. And these are my disclosures. I will speak a little bit about the epidemiology, the risk factors for diabetic peripheral neuropathy, the central nervous system involvement, a recent trial that we published in the Lancet called the OptionDM trial, and then finish with very brief conclusions. So let's kick off. Our part of the world, this part of the world, has the second highest projected increase in diabetes. As you can see, I think everybody here is well aware of that. And that's going to project to quite a lot of people in the next 20 years. And this was a paper that was published in Lancet Neurology. And you can see that the biggest, these are all neurological disorders, and around 43% of the world population is affected by neurological disorders. And stroke being the highest number, 160 million people. And they've given diabetic neuropathy 26 million people. This is a gross underestimate. As we all know, according to the IDF, the number of adults with diabetes in 2021 was 537 million, and it is now estimated, if you look at diabetic neuropathy, around 1 in 2 will develop diabetic neuropathy if you use sophisticated equipment. And around a quarter will develop painful diabetic neuropathy. In fact, in Egypt and areas around here, it's much higher prevalence of painful neuropathy. And this projects to around 250 million people, and not 26 million people that they gave us. So by far, the commonest cause of neurological disorders in the world is diabetic neuropathy. It's a very serious and important condition. I think everybody here knows that diabetes is a leading cause of working age blindness, except in the UK. And I'll talk about that in a minute. It's a leading cause of dialysis or end-stage renal disease. Diabetics have a 2 to 4-fold increase in cardiovascular mortality and stroke. And diabetes is the commonest cause of non-traumatic lower limb amputations. There is no mild diabetes. Some people are plagued with all these complications happening together. And this doesn't include autonomic neuropathy. Autonomic neuropathy can affect any system of the body. It affects the gastrointestinal system, urogenital system. The brain now, we're being alerted that diabetes is now linked with dementia. So it's a very, very serious disorder with these massive numbers of people around the world. Complications are going to be increasing, and complications are very expensive. So when you look at a patient with diabetic neuropathy, it's very easy to take history and examination. They may have positive symptoms, they may have persistent burning or dull pain, paroxysmal, occasional, ouch. In the middle of the night, they can get little electric shock jabs. Sometimes they can get pins and needles. Evoked pain is a non-painful stimulus perceived by the patient as being painful. So a little touch like this can be extremely painful, particularly with nighttime bedclothes. And it can also have paresthesias. These are pins and needles, and they can be painful or non-painful. And the symptoms generally are worse at night. We don't know why they are worse at night. It leads to insomnia, and if you can't sleep, your energy is not good enough. I arrived in Alexandria at my hotel at 5 a.m. this morning, and my energy is not very good today. So I need the audience to give me energy. And so some people can get pain on walking. A lot of people can have loss of balance, so they use this stamping gait, we call it stamping gait, to reassure them where their feet are. This is an advanced disease. It's due to sensory ataxia. They can have weakness. Again, it's a late event. Diabetic neuropathy is a sensory neuropathy mainly, but motor manifestations come a bit later on. And this leads to disability and isolation. And it is interesting, you can get a foot ulcer and pain together. Some patients with foot ulcer can have also neuropathic pain. Okay? So we have these bedside tests. They are okay. They're not perfect, but in good hands, they are okay, particularly the vibration sense. But you have to do it correctly. You have to say, close your eyes, bang, can you feel the vibration? Don't let them hear the vibration, because they'll say, yes, I can feel it, So you need to confuse them. So give them no vibration. Can you feel the vibration? They say yes. Oh, no, there's no vibration. So you need to find out if they have proper appreciation of vibration sense by closing their eyes. So it's got to be done correctly. But the vibration sense is good. The pinprick sensation, okay. Monofilament only tells you if a patient has numb feet, loss of protective sensation. It's not a good way of diagnosing neuropathy early. So we have many painful neuropathy phenotypes. Some people can have, this is a lady who went to Greece on holiday. She didn't know that she had a neuropathy. She was walking on the sides, barefoot, and she had a blister. But she still has painful neuropathy also. This is another lady of mine, actually. I did neuropathy research because of this lady. She came at the age of 29 with a nail stuck through her shoe all day. She'd been walking without knowing. And she lost that toe, and she had a good symmetry. But nevertheless, that really shocked me. And how can somebody not feel this? I need to do some research to understand this area. And again, this patient had numb feet. She couldn't feel anything, but still had pain. It's really intriguing. How do you have numbness, no feeling, and pain? Everything will be very clear after I finish my lecture. So what I'm doing at the moment is getting you ready to listen. And some people can have numbness in their feet. And this numbness is not a comfortable numbness, ladies and gentlemen. It is an uncomfortable, as if your tooth is frozen by the dentist, an uncomfortable kind of numbness. Others can have good sensation. They can feel you, but when you touch them, they have burning pain or terrible pain. Others can have, again, sensation can be intact, but they can have deep pain, like an ache. And some people feel as if they're walking on sharp things when there is no sharp things on the floor. Others, broken glass, electric shock type pain. Walking on fire, on hot sand, many descriptors of diabetic peripheral neuropathy. And not surprisingly, many patients are very depressed because this is unseen. 2 weeks ago, we had parliamentarians coming to Sheffield to look at, UK, there is an all-party parliamentary group on diabetes. Because of our work in neuropathy and the one-stop shop, which I'll tell you, they came to visit, and I had a patient with painful neuropathy, and they thought, and I had somebody with an amputation. They look at that, the patient with amputation, and they were really sad to see. When they saw the patient with painful neuropathy, she looked okay. So they were just wondering, why is she here? But when she opened her mouth and she explained how her life is so terrible, she is socially isolated, she has medications don't work for her, and they left the room feeling, understanding what it means to have pain. And a lot of patients with painful neuropathy, family members don't believe them. We've got pain, well, we look okay. So it's a hidden, and it is also a terrible infliction. Now, ladies and gentlemen, we can separate these patients, we can phenotype them into those that have numbness, can't feel their feet, and have pain. It's called, or on the right side, it's called the irritable nociceptor phenotype. These phenotypes here. I don't have a pointer. If you have a pointer, please give me a pointer. On your left side, you'll see the non-irritable nociceptor phenotype. These are patients that can't feel their feet. You put a needle through their foot, they can't feel, but still have pain. So we can separate them by phenotype, by doing quantitative sensory testing. Now, some patients don't have anything abnormal when you examine their feet. So because of my interest in, thank you very much, thank you. Because of my interest in, let's see, oh no. Yeah, okay. So this, I had one lady who came from Dubai because she tried everything, nothing worked for her, and they came to Dubai and examined her feet. She told me she gets electric shock pains, continuous. And when I examined her, she could feel her feet. We did nerve conduction normal. And we did everything was normal. But she gave you a perfect description of neuropathic pain. Is she making it up? I don't think so. And again, we'll discover why this is happening when I talk to you. So clinical physical examination and small fiber tests can be normal in some patients. They can still have painful diabetic neuropathy. Now I'm going to tell you a little story. I am originally from Africa. In Africa, we love stories. This is a patient who lost a leg when he was aged 13. At the age of 13, there was a car accident, lost a leg, but lived a normal life. In fact, the boy was a cheeky boy, very intelligent, smart, and used a prosthesis and lived a normal life until middle age. In middle age, this boy became a man and he developed type 2 diabetes. And then he developed diabetic peripheral neuropathy in the intact leg. At this point, he was coming to clinic and saying to me, Dr. TeiSfai, I was doctor in those days, this is 1998 or something like that, and he was saying to me, I have pain in both legs. Beg your pardon? I can feel pain in both legs. And he said he could make out his foot. And I was really surprised. How can you make up a foot when you lost it 30 years ago? He said, well, I'm starting to remember my foot now because I developed pain in the other leg. And this really led to an amazing series of research. We've produced about 50, 60 papers since then. And I started to think, maybe the pain is not in the leg. Maybe the pain is in the brain. So what's happening is the barrage of pain information is going from the intact leg, is going to the brain. And the brain is rewired differently because the brain is highly plastic. And he's telling this man he's got a pain in a leg that doesn't exist. And so everything will be clearer as we go along. I'm just giving you little bits like this so you don't go to sleep, okay? So we go. Now in the UK, 25 years ago, what did we do? We used to look at the back of the eye in clinic. As a junior doctor in the UK, I had 20 patients, and I had to put in eye drops and look at the back of the eye and refer patients with retinopathy. I wasn't good at it. We're not trained to look at the retina very well. And there was delay in referral. Retinopathy was the commonest cause of working age blindness. Ladies and gentlemen, this changed completely in 2005 because the government in the UK said everybody with diabetes must undergo an annual retinal screening using a digital camera. And so now in the UK, we have an eye screening service. All the patients are referred. They have an annual eye screening with dilated pupils, and we get something like this. Very detailed view. And this is analyzed now using AI. And patients are, so it's graded, and patients are referred immediately to see an ophthalmologist if they need treatment. And this has been a game changer. It led to a paradigm shift. The UK being the only country in the world where retinopathy is no longer the commonest cause of working age blindness because of early diagnosis, early treatment. Now, what can we say about neuropathy and the diabetic foot? Amputations in the UK are increasing. We had 135 amputations every week in the UK. We have a very good system, the National Diabetes Audit. We record everything and this was 10 years ago. Now it is 180 amputations. It's increasing because diabetes prevalence is increasing. And we've called on the NHS, the Diabetes UK, with my organization, and said, do something similar to eye screening. Do something. You need to change because the way we screen for foot is not good enough. Now, that was 4 years ago, 169 amputations, now 180. And many patients with painful neuropathy are not diagnosed. You see, for retinopathy, 95% are diagnosed. You have eye screening done, you're referred to an ophthalmologist immediately. Whereas for pain, the GPs don't even ask them if they have pain in their feet. Because pain is not regarded, or the foot is not regarded as important as the eye. And so 50% of people are underdiagnosed in the UK, in Germany, Spain, and the Netherlands. This is a study we did a couple of years ago and published 2023. And why is this? There is also confusion. In the UK, patients can be referred to a pain specialist. They can be referred to a diabetes specialist. They can be referred to neurologist, physiotherapist. There are many people managing pain. Not ophthalmologist manages eye. Renal medicine, kidney people manage it. Whereas pain is managed by all sorts of people. So when you have too many players, there is underdiagnosis and undermanagement. So in the UK, we use the 10-gram monofilament to diagnose neuropathy, but this diagnoses neuropathy very late, when it's reached this stage. The monofilament is a blunt instrument. Can you feel these They may, cognitively, they may be impaired, they may not, so it's a poor test. It's a good test to tell you you have a really bad feet, vulnerable feet. But it's no good way of diagnosing neuropathy early. And so patients present late. I was told my feet were fine by the annual check until last year when I was told I have nerve damage. Now I'm attending the foot clinic. So this patient was given a false sense of security. The neuropathy is getting worse and worse and worse every year. But the monofilament doesn't detect that. It's not quantitative. It is categoric, present, absent. By the time it is positive, it's too late. And you can see once they come to the foot clinic, survival is very poor. People with diabetic foot ulcer have a 5-year mortality of 50%. Once you have a diabetic foot ulcer, that's it. And I see these patients in the foot clinic, and my heart sinks because I know they're not going to live for very long. It's too late. Neuropathy is a marker of mortality. And you can see patients with diabetic foot ulcer have worse outcomes than colorectal cancer, than prostate cancer and breast cancer. Only lung cancer has worse prognosis, and pancreatic cancer. So we need to avoid that. And the cost of the diabetic foot in the UK is enormous. It's more than the combined costs of breast cancer, bowel cancer, and prostate cancer combined. It is very expensive. These patients need to come in, they need investigations, they need IV antibiotics, they need imaging, they need bypass operations, they occupy beds for weeks, and it's very, very expensive. If we do skin biopsy in patients and look at the intraepidermal nerve fiber density, that you can see these are the small nerve fibers you find on the skin and the foot skin, already when you develop diabetes, they've gone down. Already when you develop diabetes, they've gone down. And this is an early marker of neuropathy. And serial sensory conduction velocity and amplitude is also significantly reduced. But because we use monofilament, we diagnose these patients late. If you use sensitive measures, you can diagnose neuropathy early. And also, even in pre-diabetes, IGF and IGT combined, there is a high prevalence of neuropathy. Neuropathy precedes retinopathy. The blood glucose of 7 as a diagnostic measure was made because of retinopathy, because at that blood glucose you developed retinopathy. And not neuropathy. Neuropathy actually, there's more neuropathy in pre-diabetes than diabetes. So it's an early feature. One of the things that we discovered many years ago is I was seeing a lot of patients in clinic. They had excellent blood glucose levels, and yet they had peripheral neuropathy. And I started asking myself, why? It's because, and then we did a study, what is the risk factor for neuropathy? We studied 3,250 patients, followed for 7 years, and we looked at baseline markers of peripheral neuropathy 7 years later. And what we found is hypertension, smoking, glucose is important, obesity, everything gets worse, increasing duration, triglycerides, cholesterol to some extent, were markers of peripheral neuropathy. Neuropathy is not just a sugar disease. It is cardiovascular risk factors predict neuropathy. And what about for painful neuropathy? Now, we looked everywhere to see who develops pain, who doesn't develop pain. We couldn't find any, because pain is very complex. Pain has cultural, psychological, social elements to it, genetics maybe. And so pain is a lot more complex. You cannot reduce it to glucose or to blood pressure. We published this a year ago. We found that painful neuropathy was more common in women. The incident, new onset painful neuropathy was in women. And why could that be? Could it be because of sex hormones, neuroimmunity, cerebral factors, psychosocial factors. There may be a lot of factors, but we don't understand why. But it tends to be more common in women. I don't know your experience in Egypt. Now, I'm just going to show you the natural history of diabetic peripheral neuropathy. Neuropathy has a subclinical phase, where you have small fibers that are abnormal. There is a reduction in nerve conduction velocity, small fiber neuropathy, pseudomotor sweating dysfunction, autonomic dysfunction. And then it has a clinical course where the vibration abnormality is the first abnormality. And then reflexes go, and then 10-gram monofilament, and then foot ulcers, and amputation, and then death. So we are catching at the moment neuropathy here. When they diagnose, it's too late at this point. And the pain can come at any point. It can come here, it can come any, neuropathic pain is present at all stages. We now know the brain is involved in diabetic peripheral neuropathy, and this can be also early. And so it's a complex, it's not like retinopathy where you have, here there are many, there's pain, there is brain involvement, there is peripheral nerve, there's so many different nerve fibers are involved. It's a very complex area, and I'm glad that Dr. Noha Gaber is researching in neuropathy. So you've got a real star here who's researching diabetic peripheral neuropathy in Egypt. So there is a point of no return, and clearly we need to act early if we want to prevent neuropathy. Ladies and gentlemen, many years ago, I convened a meeting in Toronto, Canada, and I invited all the top people in the world, including Professor Peter Dick. He died at the age of 97 in July. He was the president of the Neurological Society of America. A great man. He helped me with this. He worked until the age of 96. And isn't that interesting? You know, some people are real academics, and there is hope for us all, ladies and gentlemen. And so, what did the Toronto Consensus tell us? All these people are from Harvard, Roy Freeman, from Paris, all the top brains. And what I asked them is this: how should we diagnose peripheral neuropathy? Because in Egypt, they're doing this. In Cairo, they're doing this. Alexandria, they're doing this. Vienna, they're doing this. Well, why can't we have a uniform approach to diagnose neuropathy, like retinopathy? Why can't we have a consensus? And this paper has been cited 4,000 times. And if you want, the younger members of the audience, if you want to research diabetic neuropathy, that's your paper that you must read. And basically what this consensus said is symptoms and signs are not adequate. You need to do an objective test to diagnose neuropathy, similar to the eye. It's no good just looking at the back of the eye. It's no good doing monofilament. If you want to diagnose neuropathy, to confirm it, you need an objective test. And so what we do in Sheffield now is the patients come, we put eye drops in their eyes. The eye drop's working, but it takes 20 minutes for the eye drop to work. They're sitting down. They can't read because their eyes are dilating. They're doing nothing. So we use that time to put them in next door, examine their feet. We use point-of-care devices. We measure cerebral sensory conduction velocity and amplitude using this equipment. It only costs $1,000. It needs a consumable. It measures nerve conduction within 33 minutes. We also use pseudoscan. You have this equipment in Egypt. It measures small fiber function. It measures sweat function. So again, it takes 3 minutes. We do a brief clinical examination. Our podiatrists do that. And we also do all the blood tests. A1C, cholesterol, EGFR, microalbuminuria testing, body mass index, blood pressure. Everything is 9 care processes done. In 35 minutes, the patient's out. This is called the Sheffield one-stop shop. And you can see if you use monofilament, you diagnose neuropathy in 14%. If you use nerve conduction, you diagnose neuropathy in 51%. It diagnoses neuropathy early. So this was during COVID. The patient, these are big GP hubs in Sheffield. We've got a few of them, and they're big surgeries. The patients are referred directly. They register. After registering, they go and have their eye drops put in, and then they have examination, and everything is put into the computer. And the results of the patient's results are available to all the doctors of Sheffield within minutes, because it's entered in System 1. We have a system that works for the whole city. And this is linked to early referral. Patients are referred early to see a nurse. You don't need a doctor. And this is done by nurses, and referral is done, and the optimization can be done by nurses. The doctor is there to give advice in terms of treatment, but a lot of it can be done by nurses. Dietitian, psychological exercise programs, diabetes education program, medication treatment to reduce blood pressure and A1C. And at the moment, we have a study called the Oceanic Trial. This trial is trying, if you Google it, Oceanic Trial, we're trying to see, can we reverse neuropathy? Can we reverse diabetic peripheral neuropathy? And what we have is a control arm where they have just normal treatment, an intervention arm where they have, you can see, CGM. Everybody with type 2 diabetes has CGM, tight glycemic control, exercise program, remote activity monitoring. We give them a watch. Body mass scanners, they can see the fat mass of their body. Weight loss using GLP-1 receptor agonists. Almost everybody is on GLP-1 receptor agonist. Sorry?
That's utopia for us.
Well, everything starts at one point. It can be done. Where there is a will. Nobody said this could be done in the UK. I pioneered this treatment. Everybody said to me, you will fail. Now, what do we achieve? Within 4 weeks, we can achieve normal blood glucose using GLP-1 analogs. They are free in the UK. They are free. I know it's expensive in this country. In the UK, all treatment is free on the NHS. And you can see that we achieve everything. The patients go on exercise programs. The weight goes down dramatically. And I will tell you in a couple of years' time, if Dr. Noha invites me again, the results of this Oceanic trial, whether neuropathy in type 2 diabetes can be reversed. So let me just quickly show you that patients with painful neuropathy, we have an MDT approach, multidisciplinary approach. We have a doctor, nurse, physiotherapist, pain specialist, psychologist, podiatrist, orthotist, vascular surgeon. We all work together in a clinic to tailor the treatment to the individual patient, depending on the complexity of the condition. Some people may not need anything. They just need medication to say goodbye. Others have a lot more complex issues, and these MDT allows us to tailor treatment to the individual patient. I started the one-stop shop in the Philippines. Doctor here said to me, it's utopia. It's not utopia anymore. Even in hospitals in the Philippines are starting the one-stop shop. Because I went there, I invited all the key stakeholders. I said, you know, do you want to prevent complications? Do you want to have a lot more patients on for dialysis? This is the cheapest way. Prevention is better than cure. And all you need to do is to get the ophthalmologist to talk to the endocrinologist. When you do that, you can have a joint clinic. It's a matter of, you know, designing and planning. Of course, there are complexities in each country. I presented these to ministers in the United Kingdom twice in the House of Commons and in UK Parliament. And the MPs came to visit during the holiday season. They came and visited our service. And this is today's news. If you put Sheffield One Stop and September the 3rd, 4th of September today, it came in the news. MPs praise Sheffield's pioneering approach to diabetes care. And the government wants now to use a one-stop shop all over the country to prevent the rising tide of complications. So quickly, Nohad, how much time do I have? Is it okay? I'm giving you a longer lecture because this audience deserves the highest quality lecture. I'm invited all over the world, but I feel specially connected to this audience because I'm originally from Africa. So, here we have, what is the cause of diabetic neuropathy? And my boss, Professor John Ward in UK, said to me, can you find out, Solomon? We know what the eye looks like. We know what the retina looks like. What about nerves? What do they look like? And so I took patients to theater. We operated on them. And we looked at the sural nerve, which is this one. And this was the theater. This is 30 years ago. And this is me before I developed the metabolic syndrome. And you can see, you can see we had a Polish neurosurgeon. He was a brilliant neurosurgeon. We have brilliant, and now the head of neurosurgery in Sheffield is Hesham Zaki. He's Egyptian. He's one of my best friends. We travel together on holiday, his family and my family. So a lot of Egyptians actually in England. It saddens me to think that the best doctors are outside Egypt. There are many, many surgeons and scientists and, who are unfortunately not in this country. So what we looked at is the nerve. This is the nerve that you can see. And these are the axons in green. These are the blood vessels, the capillaries within the nerve. And this is the big feeding artery and the vein. And so what we looked at is, when we took a biopsy of the nerve, and these are the greens are here, the myelinated fibers. You can see there is significant reduction. Diabetes destroys, neuropathy destroys these wires, these axons. How does it do it? How does high sugar, high cholesterol cause this degree of damage? So we looked at these blood vessels within the nerve, the capillaries here. When you look at the capillaries, a normal diabetic has this beautiful capillary that you can see, endothelial cell. A person with neuropathy is clogged up. These are the blood vessels within the nerve. And then outside the nerve, these blood vessels, you can see, here is a normal diabetic control. Here is a patient with neuropathy. Just to balance, because everything is on that side. Let me go on this side. You can see a normal diabetic control has beautiful artery and vein running parallel along the length of the nerve. It's only 2 millimeters from there to there. This is the nerve, highly magnified nerve. But a patient with neuropathy, the small artery goes through a rather tortuous route, often the caliber changing and joining the vein in a direct arteriovenous shunt, upon which the vein then becomes distended and arterialized, if you like. So the nerve is bypassed. There are no penetrating blood vessels. You can see here penetrating blood vessel. No penetrating blood vessels in here. So basically what's happening is all these capillaries are blocked. And blood is going from the arterial side to the venous side in these shunts, because it cannot get in here because all these bloods are clogged. So the nerve is bypassed, and the cause of neuropathy is impaired nerve blood flow. There isn't adequate blood flow. And you can see, here is a normal nerve, beautiful, lots of blood vessels, and a patient with neuropathy, small artery, big vein, the nerve remains black because hardly any blood is going through it. So we proved conclusively, and this is all in Nature now, that the cause of diabetic neuropathy is vascular disease. Diabetes is a vascular disease, a microvascular complication of diabetes. And when we looked at these small nerve fibers, we found that healthy volunteers, painful neuropathy and painless neuropathy had absent. No DPN, normal diabetics had quite a few. So, but you cannot, all these things I showed you earlier on here, they're all the same in painful neuropathy and painless neuropathy. There's no way you can distinguish somebody having pain and somebody not having pain. This could be painful neuropathy or painless neuropathy. So I'm starting to ask myself, why do some people develop pain? Others with the same degree of neuropathy don't have pain. Where is the problem? So everything is connected, as you can see here. The small, these nerve fibers, peripheral nerves, are linked to the spinal cord, from spinal cord to the brain. And I stood many years ago, in my early 30s, I think I stood in front of all the big shots in those days, P.K. Thomas, all the really great names, Peter Watkins. And I said, could diabetic neuropathy have central component? Could the brain be involved? Could the spinal cord be involved? And one of them said, I'm not going to mention who, but I said, they used to like me because I used to be very active. My dear boy Solomon, you can see where it's heading. Diabetic peripheral neuropathy has been a peripheral neuropathy for 150 years, and it's going to be a peripheral neuropathy for another 150 years. At this point, I was embarrassed, put my tail between my legs and took my seat. But, ladies and gentlemen, that is the essence of science. Ask an impertinent question, and you are on the way to a pertinent answer. Sometimes things may not look logical, but the younger members of the audience, if you are passionate, if you have an insight, follow your dream, because you might find a very pertinent answer. And so that's what we did. I wasn't shocked by the big shots. I was embarrassed on that day, but we then looked at the spinal cord. And then when we looked at the spinal cord and measured the cord cross-sectional area, in DPN, it was significantly reduced. No DPN, these are normal diabetics controls. We published this in the journal, The Lancet. It's a very good journal, The Lancet. And this was a small study. We confirmed it in a much bigger study. So we showed the spinal cord is involved. Nobody tells you spinal cord is involved. Everybody says it's the peripheral nerves. And then we went on to look at the brain. When we looked at the somatosensory cortex, we published this in 2023 in the journal, The Diabetes Care. And you can see we have big numbers. This is the largest neuroimaging study in diabetes. We looked at, you can see healthy volunteers, normal diabetics, painless neuropathy, painful neuropathy. And you can see the somatosensory cortex volume in the brain is significantly reduced in people with painful and painless neuropathy. So diabetic neuropathy is not a peripheral neuropathy. It involves the whole of the central nervous system. What about the function? We looked at the thalamus. The thalamus is a very important area of the brain. It's where pain is processed initially, before it's forwarded to somatosensory cortices. And when we looked, so we used MR spectroscopy to interrogate a special MR modality. I won't waste your time telling you how it works. We measured the N-acetyl aspartate to choline ratio, a sensitive measure of how nerves are working, how neurons are working. And you can see the levels are okay in healthy volunteers and no DPN. In patients with painless neuropathy, the level goes down, indicating the nerves are not working, the neurons are not working in the thalamus. But in those with painful neuropathy, they're hyperexcited. So what we're showing is no differences between painful neuropathy and painless neuropathy in the periphery, but in the brain, there are differences. We then looked at the blood flow in the thalamus. We injected fluorescein, not fluorescein, gadolinium. It's a contrast agent. And you can see normal diabetics and healthy volunteers have the same blood flow. But when we looked at patients with painless neuropathy, they had a slow blood flow. And those with painful neuropathy, the thalamus is engorged with blood. Now we can distinguish between painful neuropathy and painless neuropathy. So the people that have painful neuropathy have changes in their central nervous system different to those that don't have pain. Just one final study that I'm going to show you. If you remember your homunculus, this is the foot area on top. Hand is represented quite massively, and you have the face and lips are also represented quite massively. The foot area is actually quite small. And what we did was we gave them burning pain. We just gave them a burn in their foot, and we looked at the brain. And you can see healthy volunteers and painless neuropathy, the foot area lights up when you burn their feet. Painful sensate. The people that can feel their feet, again, the foot area lights up. Those with painful neuropathy, but can't feel their feet, on the other hand, there is bilateral representation. Because the foot area, excuse me guys, the front, you tell them to stop talking. In the front, what you see is here, the patients have no feeling in their feet. When you have no feeling in your feet, over many years, the brain becomes atrophied. The brain recruits a different part of the brain to process that information. Because the foot area is atrophied, so you get bilateral representation. And that's why the man, the boy that lost the leg, he, over many years, forgot about that area. But when he started to have pain, he had bilateral representation. And that's why he could feel the leg. So really, now we're gaining a lot of insight. So you can see that the people with painful insensate have a different processing, whereas those that have painful sensate have a different processing. Finishing off quickly. And what's really becoming apparent in the world at the moment is sometimes a drug may not work. So oxcarbazepine was a failed drug. It didn't work for pain. But when you divided people to those who had painful sensate and painful insensate, it worked in the painful sensate. In the irritable nociceptor, it worked beautifully. In the people that had dead feet, it didn't work. So the ability to have pain relief could be dependent on your phenotype, pain phenotype. So I think we're gaining a lot of information about really diabetic peripheral neuropathy is not just a peripheral neuropathy, but a central neuropathy. Just the last couple of minutes, I'll tell you about the paper we published in The Lancet. It's called the Option DM trial. And what we did in this trial was to compare amitriptyline, pregabalin, and duloxetine. Which is the best drug? Which combination is the best? And does combination treatment give you better pain relief than a single drug? 3 questions, 1 trial. It's a year-long trial. And you can see that with amitriptyline, if you start, when you add pregabalin, the pain gets better. Duloxetine, you get pain relief up to this. When you add pregabalin, further pain relief. And the same here. But some people respond to one drug very rapidly, only 1/3, the bottom line. We don't know why some people respond to one drug and why some people respond to another drug. But only 1/3 respond with significant pain relief. But combination treatment is better than high-dose monotherapy. So now combination treatment is advocated, as you can see. And the people that we have in the UK that don't respond to treatment, We send them for spinal cord stimulation. Again, it's free. This form of treatment was discovered by myself many years ago for neuropathic pain. It's been used many times for different conditions, but the first time it was used for neuropathic pain was when we did the study that we published in the Lancet. So finishing off, I'll tell you about what's happening. This is published in Nature recently. Some people don't know where their feet are when they're walking. And so what they have developed in Switzerland is these insoles that you can see. These are sensor insoles that send information to a processor here, and the processor then sends through, using a special sock, information to tell them where their feet are. So when they wear this, they can walk okay, no problem. So again, this is a great development. Finishing off, Dr. Gaber, ladies and gentlemen, it's a bit long lecture, this one. Diabetic neuropathy is not a peripheral neuropathy. This was published in Nature Reviews Endocrinology. It is actually involved the central nervous system. That's how we can tell if somebody is in pain. We can now see when people are in pain by doing brain imaging. And we're using modern imaging techniques, resting state fMRI, spectroscopy, perfusion imaging to diagnose diabetic painful neuropathy in the brain. I hope it's not been too heavy for you. I think we understand where pain is being processed. From there, we've come there. But we don't understand the unique individual elements of pain. Why have some people have got this feature? Other people have a different feature. What is generic applies across all pain conditions, different pain conditions. And what is generic, what makes one unique? Painful diabetic neuropathy, post-herpetic neuralgia, what is the difference and how is that generated? So many things are happening in the world at the moment. The latest things are called multi-omics approach. So this looks at genomics, so genetics, epigenetics, transcriptomics, proteomics, metabolomics. Phenomics is just looking at the component of phenotype, a patient's phenotype. And by using these, hopefully we can understand the complex relationship of phenotype and genotype. I want to thank all my colleagues from all over the world and my collaborators, all my research fellows, past and present, and I want above all to thank you for your very kind attention.
Many thanks, Professor TeiSfai, for such an elegant talk. We are so honored to have you today. So let me call upon Professor Talat Abdulati, the President of IADA, and Professor Magdi Hilmi, the Conference President. Just a small appreciation for your presence here. Allow us, please, to thank you. Thank you a lot.
Thank you very much. Honored to have you. Thank you.
Thank you a lot, Professor. Thank you. Yes, please.
Thank you.
Wonderful lecture.
A bit long, but
No, not at
it
all.
will inspire young people. Yes.
Who didn't feel the time. As to thank you very much.
Yeah, rests, yeah. I arrived late.
lecture with Laura
Yeah,
alone.
السيشن التالية may I call upon the may I call upon the chairpersons for this session دكتور عبد المعز حامد، دكتورة عزة عبد الكريم، دكتورة هند عبد المنعم، دكتور عصام ولاية، دكتور محمد عبد الرؤوف. Please.
هنعمل تعديل بس في الترتيب الجلسة بس ومدرس اسمه سوبر مانجمنت هو بس هيبقى عمرو بس وبعد كده الترتيب هيمشي عادي.